Hello everyone, my name is Erica. I'm a student at Middlesex Community College. This is NCA 2. I typically make these videos because it helps me learn it, just talking it through. I like to rewatch them. I can listen to them in my car. I know it helped a lot of students last semester when I made these. If you find it helps you, great. If it doesn't, sorry. If I say anything wrong, please email me, message me, correct it. I'm trying my best, okay? So this video, we're going to be talking about the Addisons and Cushings. And so we're going to start off with the adrenal glands. So what are the adrenal glands? So the adrenal glands are located at the top of each kidney. They are under control of the anterior pituitary gland, which also is under control of the hypothalamus. These our focus are going to be on the adrenal cortex, which secretes three hormones. The first one is glucocorticoids, and this is going to be cortisol. Cortisol is responsible for the body's immune system response. It's responsible for our, stress, and also the metabolism of fats, proteins, and carbohydrates. So if you wanted to test someone's cortisol level, it would be best to test it in the morning. That is when, your cortisol level is the highest and most accurate. 5 to 25 is going to be our normal range, and anything less than 3 is going to be indicative of an insufficiency or Addison's disease. Our next is going to be mineral corticoid, and this is aldosterone. So this is basically your body keeping homeostasis. Everyone has the aldosterone Renin cycle happening to them kind of all the time to maintain that, where you're excreting potassium, but you're reabsorbing sodium and water. The normal levels for sodium is going to be 135 to 145. The normal level for potassium is going to be 3.5 to 5. And the last one we're going to talk about are sex hormones, and this is estrogen and androgens. We're going to make our focus about estrogen because this disease typically happens in women. So we're going to focus on either excessive hair growth or no hair growth. And also the fact that this happens to women between the ages of 20 and 60 roughly, and it increases with age. So we're going to talk about adrenal insufficiency first, and so that's Addison's disease. And so what would cause a patient to have Addison's disease? So they could just have an autoimmune dysfunction of the adrenal gland. They could maybe had an adrenalectomy because maybe they had, a tumor on it or some reason why they had to get this removed. And so they now have Addison's disease because maybe they aren't taking their steroids. Maybe they had an abrupt stop of their steroids. Things like that would be indicative of why someone would have Addison's disease. And so the way I remember it is you're insufficient. You have low everything. So we're going to have low blood pressure. Why? So we know the aldosterone cycle is reabsorbing water. We are not having that anymore. So you have a low aldosterone cycle. We are not absorbing water. We are excreting our water. We are excreting our sodium. What is that going to look like in your patient? They're going to be losing weight, so weight loss. They're losing their water weight. They're going to have hypotension, low blood pressure. What do we do with someone with low blood pressure? Fall precautions. We're going to teach them to go from lying to sitting to standing. We don't want them to get dizzy. Other things we're going to do. So if your blood has a decreased amount of water in it, that makes your blood thicker. So your patients will also present with like an increase in red blood cells. That's not because their body is producing more red blood cells. It's just the concentration of red blood cells to water that we have now because they are dehydrated. Okay, so we're losing also salt. So these patients, maybe they're telling you that they've had craving for salty French fries lately. They're not craving that for fun. They're craving that because their body needs it. So they're losing their sodium, they're losing their water. What else is being lost? We're losing glucose. Why are we losing glucose? We're going to have hypoglycemia. So think about it. We talked about what happens when you lose aldosterone. So now what happens when you lose cortisol? Cortisol helps take our blood sugar and put it in our blood. So if we don't have that, we have hypoglycemia. We're going to have a decrease in energy, a decrease in mood, and a decrease in hair. So this will help you remember, because you're like, ooh, hair, which one do I remember that for? So low hair growth, no hair growth. We're going to have alopecia, so insufficient, low, no. Next, the patient's going to come in and they're going to have bronzed skin. They're going to have hyperpigmentation. They're going to look like they just had a tan. You're walking in, you're like, whoa, 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 this is not your skin tone. The patient can also just present with nausea, vomiting, diarrhea. The two things that they're going to present with hyper, so these are like two key things that you have to remember that are obviously different than everything else being low. They're going to have hyperkalemia and hypercalcemia. Why? Okay, so back to the Angian cycle. So aldosterone excretes water. So, excuse me. It reabsorbs water and sodium and excretes potassium. That cycle is not happening here. So we are not absorbing water. We're not absorbing sodium, and we are keeping our potassium. We are not excreting it. So what's going to happen? It's going to exceed the level of 5 because 3.5 to 5 is our normal level, and they're going to have hyperkalemia. What happens when someone has hyperkalemia? They're going to have muscle weakness. They could be having chest pains. We want to do an EKG. We're going to check for dysrhythmias. We want to tell them to have a low potassium diet. We might want to put them on a Lasix, obviously get their fluid status under control, make sure they're not dehydrated, but they will need, something to get all of that potassium out depending on their levels and if they're in a crisis or not. What follows potassium? So this is something that wasn't really super talked about in the book. I did a lot of my own research, and so basically it's just calcium follows potassium. And so if you have potassium staying, it's not getting excreted. Also, you're going to have the same thing with calcium. Calcium is staying and not being excreted. So you're going to have hypercalcemia, and this can present with just back pain, kidney stones, normal things when you have a buildup of calcium in the blood. So now we're going to talk about crisis. And so if I have Addison's disease, I take a steroid because I got my adrenal glands removed. So I usually take a steroid, but I went on vacation and I forgot my medication, so I haven't been taking it. That's an abrupt stop. Maybe I just got into a car accident and needed a major surgery, and so that's stress on my body. Maybe I just started nursing school and I am freaking out, my cortisol levels. So basically why someone has a crisis, whether it is like emotional stress, physical stress like a surgery, or the abrupt stopping of a medication, they're going to have a higher need of cortisol than their body has. And if that happens, then they go into adrenal crisis. Adrenal crisis is going to be like you are so hypotensive that you can go into hypovolemic shock. You are so dehydrated, your fluid is gone. You have really, really low blood pressures, and so that is an emergency situation. So to educate your patients that before this ever even happens, they should be educated to the fact that if you are going on vacation, maybe have a second bottle of medication. Maybe, if you have surgery, have it in your patient chart that you have this diagnosis, so your doctor knows to up your dosage because they know your body's going to be under an amount of stress and that you'll need that extra cortisol to deal with it. Even if you're going through a lot of stress at home, tell your doctor, have them come up with a dose and see what your levels are at and see, maybe you're having any of these signs and symptoms before it turns into a crisis. The treatment, if you were to have a crisis, is going to be immediate IV cortisol. You want IV fluids to correct the dehydration, and then you want a D5W, and that is to correct the hypoglycemia. And then again, just going into education, you really need to drive that this is going to be lifelong therapy. They can't just stop when they feel better. You want to educate them on what the signs and symptoms of Cushing's syndrome is, because if they're taking too much of a steroid now, that could make them have Cushing's signs and symptoms. So you want to educate them on that. You want to monitor, I's and O's, weights, electrolytes, blood pressure. You want to tell them to increase their carbs, increase their protein, increase their sodium, and wear a medical alert bracelet. That was a key thing that I read in a lot of things. Basically, if maybe your blood pressure drops so low, you're having a crisis, somebody found you, it really helps guide your care if you were wearing something like that to alert someone on what could be happening to you. The other one to talk about is going to be adrenal hyperefficiency. Not sure if that's a word, but it is today. And that's Cushing's. And so you can either have Cushing's disease or Cushing's syndrome. So Cushing's disease is going to be from the anterior pituitary tumor. And so just to back up, I want to talk about like the negative feedback loop and whatever. So the hypothalamus secretes CRH, which tells the pituitary gland to secrete ATCH. ATCH goes to the adrenal cortex and tells it to produce the three hormones we just talked about, the sex hormones, the glucocorticoid, and the mineral corticoid. So basically, when a patient has a tumor on the pituitary gland, they're just hyper-secreting ATCH. So it's just so much going and rushing over to the adrenal cortex, causing the adrenal cortex to be like, whoa, we have so much ATCH. We have to put out so much more of these hormones. And that's why your levels rise, and that's why you're having a hyperefficiency. So what are these patients going to look like? They're going to be big. And so why are they big? They're holding on to all of their water. So we're going to talk about the aldosterone again. So reabsorbing water and sodium, that's what they're doing. They're reabsorbing their water and they're reabsorbing their sodium. So these patients are big. They have so much water weight. They have, edema. They're going to have poor metabolism. So how is that going to look? That's going to be a poor distribution of fat. And so they're going to have the moon face. They're going to have a fatty hump on their back, the buffalo hump and moon face. With so much cortisol now, they're going to have an increase in blood sugar, so they're hyperglycemic. They're going to have an increase in blood pressure. They have so much fluid in them now, their blood pressure is going up. What happens when someone's blood pressure goes up? Not good. Stroke, cardiac collapse. They could have pre-existing conditions. This can happen to patients up until, around the age of 60, they said. It gets worse with age. So basically, you want to make sure you don't have any other comorbidities that could, stress any of these signs and symptoms. Infections. So if your cortisol level, which is your, immune response, is so high, you're not going to have, the typical fever. You're not going to be warned that you have an infection and the typical things that surround that. You're going to have poor wound healing. I don't know if this is right, but I'm attributing it to the hyperglycemia because our diabetic patients, they have very poor wound healing and skin. So you want to do meticulous skincare, gentle soaps, things like that. They have an increase in hair production, so that's how you can remember the difference. If you remember insufficient, no hair, this is hypersufficient, and so they have a lot of hair. And so think about this happening to females. They're having hair on their chest, hair on their back, hair on their face. They're having a hump on their back. Their face is getting full. They're having a moon face. It's really going to, affect someone's emotional state and how they look at themselves. And so being their support system and, emotional support system is super, super important. We talked about the fact that you are excreting potassium in a normal, run-in cycle, but these patients are hyper, so they're excreting so much potassium. That potassium is just flying out the window, and so you're going to have hypokalemia. And what follows potassium? Calcium. So you also have hypocalcemia. So hypokalemia, we want to obviously, look at the heart, maybe to give them a potassium supplement to make up for it. Maybe we want to give them spironolactone. Why? Because spironolactone is a potassium-sparing diabetic. These patients have so much water weight that we need to get rid of that and flush their system of water weight, but we do not want to flush any more electrolytes like potassium or calcium out of there. So we would do spironolactone as an option of drug choice. For the hypocalcemia, they're at increased risk for fractures and falls, and so we want to put them on fall precautions. We want to maybe have them have foods that are high in calcium. So diagnosis, how would we diagnose this patient? We can do an x-ray, we can do a CAT scan, we can look for a tumor on the pituitary gland, we can look at just abnormal adrenal glands. For your nursing, basically, the patient is in your care, you're going to be weighing them. We want them to be losing weight because they should be losing water weight. We want to monitor their blood sugars because we want them to, be normal again. They are hyperglycemic. We want to monitor their blood pressure, which they have hypertension. We want to monitor their electrolytes. They have hypokalemia and hypocalcemia, and we want those to obviously be normal. We want them to have a low sodium diet because we're holding on to so much sodium. So now we want a low sodium diet to help not hold on to any more extra water weight if we can. You can have 2 treatments, and so that would be, tumor removal And so hopefully you can just remove the whole tumor, so it can stop secreting so much hormone to the adrenal cortex, or you can, taper steroid use. So maybe because you are a woman with rheumatoid arthritis and you take prednisone every day, maybe you take too much prednisone, and so the biggest thing with this is going to be finding a safe dose for you, because you don't want to go so low that you go into Addison's, but you don't want to be as high as you are, because it's obviously putting you in Cushing's disease. So finding the right balance for you is very important. Med compliance, adjusting the dose, talking to your doctor at times of stress or times of not of stress. And then also for Cushing's, you should be wearing a medical alert bracelet. So if you do have an incident, it can easily be handled. That's all I have for those two. And thyroid, hyper, and hypothyroid will be up next.